Hello and welcome to the DESERA Clinical Education and Medical Specialties podcast, formerly the Clinical Care Options podcast. I'm your host, Zachary Schwartz. This is the first of 3 episodes from our live event, Raising the Bar, Innovations in PBC Care. In this first episode, we discuss how our understanding of primary biliary cholangitis is helping to redefine and elevate PBC treatment goals. This discussion is led by Dr. Alia Ghulam Hussain, Assistant Professor in the Division of Gastroenterology and Hepatology at University of Toronto, Canada. She's joined by Dr. Christopher Bowlus and Dr. Aparna Goel. To follow along with the slides, visit the show notes. Now let's get started and listen in to Dr. Ghulam Hussain.
So my job was really to discuss risk in PBC and treatment targets. So we all know that PBC is a chronic cholestatic liver disease, and in patients diagnosed with PBC, treatment is lifelong. So here you see data published by the Global PBC Study Group that looks at the impact and outcome benefit of ursodeoxycholic acid in transplant-free survival in patients with PBC. And in the Kaplan-Meier curve on the left, you can see that patients who are treated with ursodeoxycholic acid have a statistically and clinically significant benefit in transplant-free survival with treatment, and that benefit is actually independent of treatment response. So the Kaplan-Meier curve on the right shows you that even in patients who we define as having an incomplete response to urso, whatever response criteria you think about, those patients still derive transplant-free survival and overall outcome benefits from treatment with urso. So the take-home and learning point from this is that if a patient is diagnosed with PBC, they should be started on urso, and that treatment, so long as it's tolerated, should be continued for life. So how and when should we assess risk? Risk we've historically thought about as it relates to treatment response. And one of the things that people think about are response criteria. There are several response criteria that have been published. It gets complicated when you try to remember the details, but conceptually they are the same. The lower your ALP is on treatment with ursodeoxycholic acid, the more normal your bilirubin is, that's associated with an improved survival or an improved outcome. So there's Rochester criteria, the Barcelona criteria, Paris 1, Paris 2, Toronto, Rotterdam, and Poise. The details, as I said, are not that important. I highlighted the Toronto criteria not because that's where I live, but because the response criteria of an ALP of less than 1.67 times the upper limit of normal is what you'll recognize as the primary endpoint that's been used in the clinical studies that have evaluated second-line therapy. So again, the more normal your ALP is, the better, and this regulatory response criteria of 1.67 times the upper limit of normal is what you'll see as in the clinical trials. So this data looks at the, again, Global PBC Study Group data and response with ALP and bilirubin. So this was a meta-analysis of 15 North American and European patients included, almost 5,000 patients, and showed that a normal bilirubin independent of ALP was associated with outcome benefit. So important points are that surrogate endpoints in PBC have been validated and are really important at predicting outcomes. So bilirubin and ALP are important predictors of outcome. You can see that the curves in blue represent those patients with a normal bilirubin, in orange with an abnormal bilirubin, and those with a normal bilirubin independent of their ALP do better in terms of transplant-free survival. And biochemical response is no doubt important, but that's not the only thing that you should be thinking about when you're assessing patients' risk in those with PBC. Their blood tests are relevant, but other factors that you should remember are what is their age at diagnosis. Because urso slows disease, urso doesn't necessarily stop disease. So patients who are young at diagnosis have to live with their disease for a long period of time, and they still have risk over time of developing outcomes. So biochemical response, age at diagnosis, the precise cutoff is not entirely clear, but I tend to think about an age of less than 50 at diagnosis. And then histologic changes or biochemical risk stratifiers or other risk stratifiers like liver stiffness. So fibrosis stage is also an independent predictor of outcome in patients with PBC and should be considered alongside age and biochemical response when you're assessing someone's risk. And this goes to show that biochemical response and fibrosis stage are independent predictors of transplant-free survival. So patients with advanced fibrosis, be that F3 or F4 on biopsy or elevated liver stiffness measures, those patients, even mildly elevated liver tests, have an increased risk of outcome. So assessing someone's fibrosis stage, however you decide to do that, rarely with histology, but with non-invasive measures, either biochemical risk stratifiers or liver stiffness, is a really important thing to do when you're assessing a patient with PBC's risk. And this is just to show the data about liver stiffness and thresholds of risk. And again, we try to divide these into sort of discrete cutoffs, mostly to remember sort of that there are levels of risk associated with FibroScan level, but we also know that there is a continuous risk based on elevated liver stiffness. So this just categorizes patients with PBC into low, medium, and high risk cohorts based on liver stiffness at certain thresholds. So low risk cohort being a liver stiffness of less than 8 kilopascals, a high risk cohort being having a liver stiffness of greater than or equal to 15 kilopascals, and a moderate risk in between. And again, this is from a large series within the global PBC study group. And that's assessing liver stiffness or fibrosis stage at baseline, but the dynamics of liver stiffness are also relevant. So this is data that shows that changes in liver stiffness over time, in the figure on the left, is associated with outcomes. So a rise in liver stiffness over time or an improvement in liver stiffness over time is associated with a worse or improved outcome, respectively. And more recently, there's data, again, from global PBC that shows that the recent liver stiffness is actually a really strong predictor of outcome. So you don't have to worry about, this patient was initially seen 10 years ago in an outside clinic. I don't have what their first FibroScan looks like. A FibroScan cross-sectionally, even at the time you're seeing them, is a relevant and a strong predictor of risk. And we'll move back to biochemistries again. The conceptual point is that biochemistries, a bilirubin and an ALP, are really strong predictors of outcome in patients with PBC. And maybe our thresholds that we've been thinking about can even be improved upon. So this is data that shows that a bilirubin level of less than or equal to 0.6 times the upper limit of normal is associated with an improvement in survival and a decreased risk of liver transplant, above and beyond patients that have a bilirubin between 0.6 and 1 times the upper limit of normal. So now that we have, in the era of just using URSO, we kind of risk stratified patients based on biochemical response or fibrosis, but we didn't have other options to really target what we now call sort of deep response, really normal bilirubins and really normal alkaline phosphatase. But how low is low enough? And again, this is data that shows that, while we had these response criteria that show 1.67 times the upper limit of normal or 1.5 times the upper limit of normal, is associated with benefit, what about those patients that sit in between, right? And this will show you that patients that have an ALP that's normal have outcome benefit compared to patients that you let live in this 1 to 1.67 times the upper limit of normal. So maybe those targets aren't enough, right? Maybe they are regulatory targets as they are, but ideal targets perhaps really should be normalization of liver tests. And that's especially true for patients with advanced fibrosis. So remember, we talked about age, fibrosis stage, and biochemical response. And in those patients with an elevated liver stiffness, so the figure on the right, here defined as a liver stiffness of more than or equal to 10 kilopascals, those patients derived the most benefit with normalization of liver tests. And this translates into real numbers, right? Absolute survival gain in months, right? So this is meaningful and what patients want you to be able to know and tell them, right? So if you look at the entire cohort that was studied in this paper, which was more than 1,000 patients, this is looking at complication-free survival at 10 years. So in the entire cohort, you can see that there's an absolute survival gain of about 7.5 months in patients that you push to normalization of ALP. Whereas if you look at the cohort of patients that is less than 62 years old or has a FibroScan of more than 10 kilopascals, again, a small number, but still an absolute survival gain of 52 months, right? That's meaningful. And so I think this paper uses these thresholds of less than 62 and greater than 10, but conceptually a young patient with advanced fibrosis is the one that you should think about for really pushing towards normalization of liver tests. Okay, so that's all I wanted to talk about in terms of a didactic assessment of patient risk, and we'll move on to talk about cases, which I've intentionally made, I think, a little bit challenging. So the first one is a case of who to treat. So this is a 68-year-old woman with PBC who's referred for further evaluation. Her medical history is significant for celiac disease. She's compliant with a gluten-free diet, but otherwise she is completely well, highly functional, working full-time. Her current medications include ursodeoxycholic acid alone at 1,000 milligrams a day, which is appropriately dosed for her weight, so that's at 15 milligrams per kilogram. Her history of disease is such that she was diagnosed with PBC 6 years ago. She has no itch. She has mild sicca, so dry eyes and mouth. She has no symptoms of advanced liver disease at all or decompensation. She is adherent to therapy, and she's referred to you for ongoing elevation in liver tests despite appropriately dosed and urso and adherence. So these are her labs and imaging after 1 full year of ursodeoxycholic acid. So investigations-wise, she's AMA positive. She's also GP210 positive, but otherwise serologically negative. Her transaminases you can see here. So she has a mild anicteric hepatitis. Her AST is 42, ALT 55, ALP 195 with an upper limit of normal of 120. Her GGT is elevated, but markers of liver function are normal with a bilirubin of 1.2, INR of 1, and platelets of 150. Her ultrasound shows mild surface nodularity with a spleen of 11 centimeters, no nodules, and a normal biliary tree. And her liver stiffness is 9.9 kilopascals. So for the panel, let's put access to treatment aside because that's going to vary across place you live and reimbursement, all those things. So put access to treatment aside. So for this patient, again, she's 68. She has a mildly elevated ALP that may not meet thresholds of 1.67 times the upper limit of normal. And she has a liver stiffness that's not quite 10, right? 9.9 kilopascals. So would you recommend adding second-line therapy for this patient?
I can give my initial comments. So how to treat this patient. So I think a few things. One is this person is on ursodeoxycholic therapy, and I think ensuring, one, that the weight has not changed, so that you are adequately weight dosing it. I believe you did say they were already on 15 mg per kg per day, and that they're compliant with it. And if you can ensure both of those, and if the ursodeoxycholic acid has been optimized, then you're looking at someone that is 60s with sort of, borderline advanced fibrosis and potentially at risk. And before, I would say 5 years ago, I would leave this person alone. I'd say, you've met the threshold of 1.67 times upper limit of normal. That's good enough. Let it be. You'll be fine. But I think now we have something better that we can potentially provide. So I would have a discussion about trying to push the threshold lower, especially if there's not any significant other comorbidities that would markedly shorten this person's lifespan. So I would consider second-line therapy.
Chris, what do you think?
Yeah, so can you figure out what 1.67 times 120 is weekly?
It's not quite. It's like 1.
Because only hepatologists would come up with the threshold of 1.67 times the upper limit of normal, which is about 200. That's kind of what I use in my head.
Yeah, exactly.
So that's my threshold. So anybody out there that's kind of wondering just look at 200. But it's not an absolute either. And so you do have to take into consideration other factors. And I think the ones that Aparna mentioned are important. I would also say that you notice the bilirubin, which you showed, is, maybe it's within the normal range, but a 1.2 total bilirubin is not normal.
Right.
So there are some concerns here in this patient. I think we all see that. And so, yes, I think adding a second-line therapy in this patient's pretty straightforward, and I think definitely we'd want to do that, even though, she's not the younger age group and things like that, but she's clearly advanced. And honestly, she's 68, I think you said?
Yeah.
So chances are she's going to live at least 20 more years.
Right.
I mean, so in 20 years, if you don't do something, she's going to decompensate.
Right. So I agree. I think conceptually what this brings out is that you think about these factors of age, fibrosis stage, and what their blood tests look like. And while we've made these binary categories or these discrete categories, they don't necessarily have to live like that in the real world, right? You think about ALP as a continuous variable. A FibroScan threshold of 10 doesn't mean 10, and 9.9 isn't high enough. So I agree. I would start second-line therapy in this patient after having a discussion about risks and benefits and in conjunction with what the patient wants. And evaluating comorbidities, I think, is really important. So let's turn it around and say, what if the patient's ALP was 1.7? And so for Chris, that's 1.4 times the upper limit of normal, or 1.3 times the upper limit of normal, and her liver stiffness is 7. Would you recommend adding second-line therapy in that patient? Aparna, what do you think?
This, again, not necessarily meeting the prior thresholds that we're using, but if age aside, I think that you could still make an argument that normal is important. So pushing to ALP normalization and trying to get it down is important. I think what would really push me in this, if all the other laboratory values were the same, what would really push me to add second-line therapy is actually the bilirubin. So the bilirubin being 1.2, even if your alk phos is like this, I do think I would really try to press to bring the bilirubin down.
Okay.
So I would add second-line therapy still.
Yeah, and I agree completely. I think this is one of those ones where you have that discussion with the patient. And again, assuming the bilirubin's that high, I'm going to be looking for Gilbert's or something else that's causing it, because typically, if they're not fibrotic, if they're not nodular, I'm assuming also their platelet counts are normal.
Yeah, platelets are 150. There is a little bit of nodularity on their
still
imaging.
those things, and I'm still concerned even if their liver if the only thing changes liver stiffness and maybe a little bit lower alk phos. I think we have to take the whole picture of the patient.
Right.
You can't just rely on an LSM. We know how variable those are. So if you have those other warning signs, that tells you something. And I think you probably would push and want this patient to be on a second-line therapy and get it to normal.
Yeah, I mean, I think I agree too. I think a conversation with the patient is really important. And, you know, some patients may say, I'm not sure I want therapy at this stage, but then it's a chronic disease, right? You have the luxury of sort of monitoring over time and saying, if you don't want therapy today, then our thresholds for initiating therapy down the line may change, or if things change. So I agree. I would probably have a low threshold for this patient if they were agreeable, and we may change over time.
I think one more quick comment is a very common coexistent diagnosis in our people living with PBC is osteoporosis, so bone disease. So I don't remember if there was a GGT value that was
high,
elevated, but just ensuring that the alkaline phosphatase is truly coming from the bone, especially when it's at that threshold, ensuring that it's coming from the liver and not the bone, especially when that threshold is like 170, 160 or so. So confirming that it is truly a hepatic source, and that's the etiology of the ALP elevation.
And weight-based dosing, as you mentioned, and ensuring weights haven't changed. I think that's helpful.
Thank you to our faculty, and many thanks to you, our listeners, for joining us. To hear the other episodes in this program, Innovations in PBC Care, or to follow along with the slides, click the link in the show notes. And to get access to all of our new podcasts, subscribe to the DeSera Clinical Education Medical Specialties channel on your favorite player. Thank you, and we'll see you on the next podcast soon.